Good morning, everyone, and welcome to today's webinar presentation on applying trauma-informed care to intimate partner violence. My name is Sarah Carsley, and I'm Applied Public Health Science Specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin, I would like to acknowledge and respect the land, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I am in Toronto, on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys and worldviews. May their wisdom always guide our own path forward with open hands, open hearts, and open minds for the mutual success and benefit for all in Ontario. I would now like to introduce my co-moderator for today's session, Dr. Susan Jack. Dr. Jack is a professor at McMaster University's School of Nursing and is a leading voice in public health nursing. She develops and evaluates interventions to improve maternal, infant, and family health. As head of the Public Health Nursing Practice Research and Education Program, or PHN-PrEP, she advances research, practice, and education to drive meaningful change. Welcome, Susan, and I'll pass it over to you.
Good morning, everyone. Thank you so much, Sarah, for the land acknowledgement and for welcoming everyone. It is a crazy snowy morning out there, so I hope everyone has either able to stay at home or has arrived safely at your office. And for those of you who are able to join us today, thank you so much. You're really in for what I believe will be an inspiring and thoughtful session today. I have known Dr. Annie Lewis O'Connor for maybe almost 2 decades through my work with an organization called the Nursing Network on Violence Against Women International. And I have always been inspired by Annie, and I learned so much from her. Dr. Lewis O'Connor, to me, is one of those rare nurses. She's a nurse practitioner whose work fundamentally changes how, as nurses, we think, how we communicate, and how we care. And in the United States and globally, truly her leadership in violence research, and as one of the first nurses really to think about and write about trauma and violence informed practice, her work, her writing has always pushed me and so many others to become better, safer, and more compassionate clinicians. And I know that she, to this work, brings deep clinical wisdom, intellectual rigor, and the kind of joy and authenticity that reminds us why nursing matters and why the work that all of you do makes a difference in the lives of women and families. And it's my honor to welcome her today. And, more officially, Dr. Lewis O'Connor is a pediatric and women's health nurse practitioner. She's the founder and now the director of a trauma and strength-informed clinic at Brigham and Women's Hospital in Boston, where she's also the director of research and innovation for the global nursing for the Center of Nursing Excellence. And her current research, aside and alongside her clinical practice, explores the feasibility, acceptability, and impact of trauma-informed care plans in healthcare software systems, EPIC, from the perspectives of patients and clinicians. So really, it's my true honor to welcome you, Annie, to Canada.
Oh my goodness, that was absolutely beautiful. Thank you so much. I um I have so much respect for my colleagues to the north, and I do want to tell you today, please keep that cold weather up there. We have had such blistering cold weather this past week, and my mom is Canadian, and I think at a young age, had a tolerance to cold, but as I get older, I'm like, oh boy, this is some cold Canadian air coming at us. So thank you for that really lovely introduction, Dr. Jack. I am absolutely thrilled to be here. I was sharing with many that I've been working with in preparing this talk how much fun I had looking at your literature, making it Canadian centric, and I'm going to learn just as much today as I'm going to share. And I, again, am completely honored to be here. We can go to the next slide. Um, I, this disclaimer, as you can see, basically that any application or use of this information is the responsibility of the user, and PHO assumes no responsibility or liability for the any such application or use. I can go to the next slide. So my story did begin, actually, Susan, you mentioned it, with the Nursing Network on Violence Against Women. At the time, I had completed my public health degree, and that was probably, out of all my education, one of the most impactful. And I went to this conference, the second conference on the Nursing Network and Violence Against Women, and met many of the personal acknowledgement folks that I have here on the screen. And I think after the fourth meeting, I said, I'm going back to school to get a PhD. And I'm going to join these ladies in doing research around this topic. And so I hope I didn't miss anybody, but right off of the top of my head, all these researchers and scholars, all nurses, have really informed me over the years, and it is always a pleasure for me to share any kind of space with them. And so I did want to acknowledge them. I'll take the next slide. So we know that talking about trauma can be difficult, and we also know that it's necessary. I'm very sensitive to the fact that every time I have the privilege to address an audience, that even within that audience, people have had their own experiences, and for all I know, they could currently be going through a difficult time. I always encourage people to not think of self-care as selfish, but to really take care of yourselves in ways that work for you. Listen to your body. And when it is feeling dysregulated, find the tools that will help you to get your feet back on the ground. So do take care of yourself during this talk. I'll take the next slide. So the three objectives you can see here, I'm going to define trauma as something that the team that had the pleasure to work with now for 15 years have come to define. Talk about trauma-informed principles and how we can apply them in our respective areas of delivering health, and how we can develop a plan with patients. And I really want to emphasize the with there. So it's not developing it to or for, but with patients. I'll take the next slide. So I'm going to ask you during the rest of our time together, you're going to hear something I'm going to say, and you're going to go, wow, I never thought about that before. I'm going to ask you to write it down. And I'm going to ask you to share in the chat at the end of this talk one thing that really, or two things that really struck you, and something that, as you go back to your clinical areas, that it's going to be something that you're going to lead with, that you're going to change. And I'm going to ask people to share that. So if you have a pen and paper nearby, just write down a few things. Next slide. So let's start with just a little bit of data. I love looking at data, but for the purposes of our time together, I'm just going to touch the surface. Um, we've had population and epidemiological studies over several decades that continues to reveal to us the incidence and prevalence of data. And clearly that alarms us, that the prevalence rates and current incidence rates are still warranting our attention. Data from cross-sectional surveys conducted in Canada in 2018 actually found that 44% reported lifetime IPV, which is significantly higher, as you can see from the global lifetime prevalence that was reported out by Sadinha in 2000. I think that was 2002, yeah. And Canadian, and specifically um, nursing researchers have been in the forefront of pioneering research, creating a body of IPV evidence that has really long informed the field around prevention, tertiary care, and services. Um, Canada's national policies, such as the National Action Plan, which, as you can see, I'm learning as well here, really how it provides for shelter services and crisis lines and sexual assault centers. To me, and from my perspective, Canada has really had this steadfast commitment through funding, through policies and research, and in my opinion, really serves as the North Star for education, research, practice, and policy. So heartfelt thanks. I'll take the next slide. So I am often asked about um, why. Why did I go into this area? I think that early in my career as a nurse working in a children's hospital ER, I witnessed patients being brought in that had been abused, intentionally abused. And I was a very young nurse, and I was just horrified that as a parent, someone could do that to their child. And I just had to learn more. I wanted to learn why it happened, how it could be prevented, um, and I also wanted to understand from the perspective of the parent, because at that time I was a young single parent. And even though I think rearing children, you have those moments, I could never imagine crossing the chasm and harming a child. I also had three patients, and I can name them all, that were murdered. And all three were strangled. And the first one was really hard because it was early. It was in the 1990s, and we weren't learning much in healthcare about screening and interventions. I think it was in the 80s that the literature really started to pick up. Um, and so that one I'm always going to feel a little sad about. The other two, I felt as though we did a lot, and we can be at peace with that because we did do safety planning, and even though we lost two more patients. Reading the healthcare consequences and understanding that from Jackie Campbell and all that came after Jackie at John Hopkins, and looking at the associated healthcare consequences just astounded me, that that these are diseases and illnesses that we can do something about. Um, I think that the news accounts every day. I don't know about what you're reading up there, but I do read a couple of papers every day, and every day there's a story. And I read the stories with curiosity. I want to know why it happened, how it happened, where were the opportunities that were missed. And we have a case right down the street from me now where a father murdered his 39-year-old wife with three small children, all under the age of 5. And, I read it every day because I am curious, because this family looked like a family in my neighborhood. And I, it makes me sad, but it also makes me want to figure out what could have been done. Where did we miss it? We did have death review in this state, and then that sort of fell apart. And again, trying to get a death review committee back together in this state. We know about the costs, we've seen that. And I do believe this is preventable and treatable. So for me, all these reasons is why I do this work. And I also want to say that as the director of a trauma-informed clinic, the data looks great. the patients, they soar. They really do. They heal when we put the right services in place. So I always ask people that feel sad for the work I do, you don't need to because I actually love the work I do, and I love that I can watch patients over a period of time heal from the trauma they've experienced. So I'll take the next slide. So what you are looking at here are the your framework, which is the four principles of trauma um, and violence informed approaches. And then below that is SAMHSA's, which has been sort of my compass for a while. And SAMHSA is a substance abuse mental health service administration. And I think what you can see here, number one, that the two of them are somewhat synergetic, right? They have a lot of the of similar themes. I think the TBIC was really visionary and it was in the forefront and focused on structural and systemic violence. And while that's not explicitly said in the TIC model, I can assure you that the team that I've been working with has taken the work of Colleen Varco and integrated it and makes sure that we do talk about those structural and systemic forms of violence. Um, the TIC I became super interested in when it first was released in the mid 90s because it was the voices of survivors that informed it. They all had lived experience. And basically, during a 2 day conference that was actually scheduled to understand from a survivor's perspective their experience with healthcare systems, I just thought these principles made so much sense to me. And I pivoted pretty quickly from that medical model, which is very prescriptive, to this model, which made me feel more engaged with patients, centering them more than what is sort of prescribed. And I think the two of these models work beautifully together. And you'll hear me say TIC a lot because I've been saying it since the 90s. But I also feel that because of your work up there with TV, TVIC, that it's really informed us down here in embellishing and in synthesizing it into the TIC model. I'll take the next slide. So this is sort of where the team that I work with got to in this Venn diagram. So I do want to say that all the work I have done it in interdisciplinary formats. In my writing teams, in my research teams, um, and in this work, we have and will always remain interdisciplinary. So my colleagues on here are a ED physician, a primary care doctor, a psychiatrist, social worker, advocate. And I often will include patients. So as this model was being developed, we would, with patient advisors, and those advisors have helped me all these years with the clinic. Um, Advisors will look at things like this and give us feedback. So I think that's a key element of the work I do is to always include those who are going to be the end receiver of whatever it is we're doing. So you could see individual, interpersonal, collective, and structural. And what I want to say about this model is that these aren't mutually exclusive, right? In fact, we see a lot of intersectional trauma here. But for healthcare providers, I think often when they think about trauma, it comes from the framework of their work. So an ER person is going to say, oh, it's, the motor vehicle crash or the MI that just came in. But a nurse working in oncology might say it's the end stage cancer patient. And so we felt that it was really important to define trauma broadly. And this diagram sort of gets us at talking about the various ways in which people experience trauma. Take the next slide. So I did a little research here, and I found that this is where I enjoyed reading some of your documents. Um, this was from a report that came out in 2020, and I really love this report. And I believe, Dr. Jack, that you were the external reviewer on this, and you can correct me if I got that wrong. I was reading a few things. But the few takeaways I got from this, and you have the link there, if you haven't read through it, even though it came out in 2020, it still has some really rich and valuable information in it. And particularly the multi-sector, multi-component approaches seem to be most effective. And I love seeing that in writing because I do believe that the system needs to be made easier for the users of it. And having someone go to multiple specialties all over the place, I don't know that we set them up to succeed. I think that that often can set them up to fail. Even my clinic is very much like a medical home model. So we grew into a space where all the services that may be needed by that patient are all housed together. The other thing I really liked was the home-based interventions. I mean, the nurse-family partnership, evidence-based, free home visiting has really showed significant benefits in maternal mental health and reduced IPV. So I loved reading that in the report, and I am sure since this came out in 2020 that there's been quite a bit more research that's come out. I really love the piece on the school-based interventions. And as nurses, I always love that opportunity when a school calls and they ask nurses to come. Those are great opportunities for us to go into schools and to talk with the kids there. But I love that it really showed that boys that were in the intervention group were less likely to engage in dating violence than the boys that were in the control group. So really good work that I think synergizes very nicely with the work that we do as nurses. And this review addressed an initial assessment of the types of intervention that specifically addressed ACEs in Canada. And it was informative in understanding sort of the vast evidence-based interventions that have been developed in Canada, and quite frankly, should be replicated in many other places around the world. So I shared that report, and that's just a quick synopsis, but excellent. I really enjoyed reading how Canada is specifically trying to mitigate the effects of ACEs and reduce mental health. So fantastic. I'll take the next slide. So I think what I want to say here is that I think if you click again, there's, there you go, perfect. So here we are working in places where we see and we witness illness and sickness, and some of us, witness death. And many nurses that worked during COVID in hospital settings witnessed incredible, like I've never seen in my life. I've never seen sickness like that. And yet I have traveled to disaster areas. I was in Haiti after the earthquake, but I never saw illness or sickness like that. And that it does cause a moral distress in us, and that I read, at least here in the States, how workplace violence has increased. We're finally coming to grips with the fact that microaggressions are ever present in the workplace, and that there are these hierarchical dynamics. So healthcare in and of itself and working in it can be traumatic for many of us. Um, and there's a better story here for sure. But I think we have to acknowledge it, and it's taken us a while to get there. I'm not sure if this was sort of in your early days as nurses or leaders in the field, that you were just told it was part of the job. And, maybe you're not strong enough, like, crying as a baby passes, right? And I was told that, well, you should be thinking about whether you can do this or not. And so we were just told to accept it, and it was part of the work. And I think we realize now that we got that wrong. Take the next slide. So these are some of the personal and organizational things that we see that are traumatic in healthcare. And as I go through many of these next slides, I am thinking about not just patients. I'm also thinking about my colleagues, staff, leadership. I think about all the people that actually work in the organization. Um, and these are many. I'm not going to read these slides to you. I'm going to highlight a few, and you will have a copy of the slides. I shared them. Um, the microaggressions has been something that we've avoided for a very long time and actually did not come to light um, until we had a bunch of trainees, first year medical students that got together and shared with us how they felt during their medical school education and how they're now feeling as they move into residency. And that was a real eye opener. And I don't know that we didn't recognize it as much as we did recognize it, but we were silent. And it's like, we're not going to talk about that. I'm glad that I stayed in the field and that I continue to be part of the solution, and that the stigma around talking about racism and microaggression has really, at least here in Boston, come a long way in the last 5 or 6 years. So it's taken us a really long time. Um, Making assumptions, I think, is a big area, both personally for personnel issues and for organizations, is making assumptions of what the staff need, what our patients need. So those assumptions can often get us down the wrong path. And I'm going to talk a lot about assumptions and stigma in this talk. And then the lack of curiosity. So my mom told me I drove her crazy as a kid because I would just always say, "So why? And how come?" And because I'd just always been curious. And I am curious when I see policies and procedures come out, and I do not feel that the person that this is going to impact was involved in it. And a good example of that is the electronic health record. That was created by some really smart people, and I've embraced it. But boy, when I was first using it, it was really clear to me that as a nurse, as a nurse practitioner, we weren't asked, because I wouldn't have put that button there, or I would have put it over here. And if you think about what we do day in and day out, it often is we're developing things for people um, because we think we know what's best. Um, and I hope that's one thing everyone comes away from. We have a lot of knowledge and we bring a lot to the table, but there's always a piece missing. And that piece is the voice of the person it's going to impact, and what do they think about our idea. And so I'll take the next slide with that. Trauma-informed care, trauma and violence care, it really it addresses a number of issues, I think. The twin public health crisis of looking at traumatic life events and systemic racism. And I do, again, want to call out Colleen Varco, because I remember the first time she spoke on this, I think we were in Vancouver. Chris King and Josephine Ryan, two colleagues that started the Nursing Network on Violence Against Women, were there. And she gave this talk that really still has stuck with me all these decades later, um, because it was new. It was a new topic to me. It was not something that was ingrained in any of my training. I had not yet gone to public health school. Um, and right then and there, I knew that this is something that is traumatic and needs to be addressed. We also know that it can change our culture. It can change the way people think. It can suspend judgment, and it emphasizes really this connection and curiosity. I feel like it's a vaccine that embodies a do no harm approach. And I have signs around the clinic around do no harm and have people consciously think about it. And I believe TIC doesn't merely address surviving as much as it does thriving, healing and thriving. And so for me, for all these reasons, I think that this is the correct model to be using. Next slide. So I know this is busy, but I'm gonna walk you through it. Human stress response is really a normal protective and primal system that alerts and prepares us, right? And it supports the body in defending against stressors, threatening normal homeostasis. And during episodes of acute stress, the physiological system supports the body's acute needs. Simultaneously, once the stressor abates, the body adapts by returning to this pre-stress condition. So why am I saying all this? Because if we have patients that are before us and they are in that far right box there and they're dysregulated, um, anything that we try to do clinically with them at that point, um, based on what their visit type was, is probably not going to be successful. We need to at least get them regulated somewhat. Um, And and so you all are aware of what happens in the brain, and we kind of have, that response triggers um, the endocrine system or the immune system, and there's also a behavioral reaction. And an example I like to use is say you're going to work every day, and as soon as you get into the parking lot, there is this big animal coming at you. It's not leashed and it's coming right at you. And you jump back in the car and you lock the door. Eventually you see that the dog goes away. But you're not ready yet to get out of the car. You sit there a while and then you decide, you know what? I'm going to move the car. I'm going to go somewhere else and park somewhere else. And you do that. And again, that animal comes back. When this gets repeated over and over, we know that people become dysregulated, that they develop this allostatic load, that then we know does lead to disease. And we have some studies in our endocrine department right now that are looking at toxic stress and measuring cortisol levels. And I think the literature has made assumptions about the link between diabetes and toxic stress, and certainly does make a lot of common sense when I think about it. So the fact is that influence response to stress that are both psychological and physiological really include the stressor's context, the duration, the dose of it, and the developmental stage, as well as one's individual socioeconomical and cultural circumstances, which can mitigate or can enhance that stress response. So we know the toxic stress will disrupt our homeostasis and leading to this allostatic load. And I notice this in a lot of patients, and we are trying to do innovative and creative things in clinic like Reiki, virtual reality, and hoping to get some funding so that we can start looking at those physiological responses and seeing if some of these innovative approaches can address the toxic load of stress that these patients are experiencing. I'll take the next slide. So I love this, the 4 Rs. So once we realize the impact, and I think we do, we can then go on to recognize how it impacts people's health and then respond in ways that are meeting their particular needs, with the goal always thinking of how can we not re-traumatize. And I do think a lot about this as an example, the ER, when patients come in and they're dysregulated, as I showed in the previous slide, they're not going to hear you. They are not grounded. And oftentimes our reaction, and this was certainly my reaction, I would just snap my fingers and call security. We've done a lot of work in this area that we should be proud of. And we weren't proud of the fact that patients were getting injured, medical restraints were being used more often than not, and staff were being injured. And realizing that this was probably not our best approach, we started with a simulation lab applying trauma-informed care using standardized patients. And the data, that study will be coming out soon. I can't wait to see it all. I know some of the results, but we do know that using this format, we have decreased the use of medical restraints, injuries to staff, and injuries to patients significantly. So sometimes our approaches aren't right. How we respond is the way we've always responded, but that doesn't make it right. And we were wise enough to stop and pause and look at that. I'll take the next slide. All right, we're going to look at some solutions. I'm going to give you a lot to think about here. You might want to pull your pens out. First of all, we just need to look at this as universal precautions. And I often will get calls from around the campus, the ER in particular, saying, we have a patient down here, and I know you talk about that trauma-informed stuff, and we think that that's maybe what we should do with this patient. Well, we've now moved from that to this universal precautions, which is we should think this way no matter who the patient is, because we don't know everyone's complete life story. So if we think about it, universal precautions. I'll take the next slide. And this is the part that I think makes sense to me. This is a shift, and this is not asking any of you to do more work. I really do want to emphasize that. I usually put that in 4 times during the talk because asking people to do more work today is already a setup for failure. So it's not more work. It's reshifting and rethinking how you do your work. Okay? It's a shift. So instead of what's wrong with you or what's the problem or what's your chief complaint, how about has something happened? Has something happened that you'd like to share with me? And how has what happened affected you? Now, I know that in Epic we have, that's our electronic health record, we have chief complaint. And I am determined to get that out and have it as the patient's chief concern. Just labeling it as a complaint, I think, is a problem. It's what happened, and what would you like to tell me about that? And that's a big shift, right? Just that, so that's not more work. I see a lot of thumbs going up. That's not more work. It's just a shift. Next slide. So, and you can click 2 more times on this one. Great. So I can't see you all, but I'm hoping you'd all raise your hand to the question. do you have some unconscious bias? I'll put my hand up. And it's everywhere. And, bias is really this decision that we make so quickly that it occurs to us that it's data, right? Or we're acting like it's real data. But is it real data or is it preconceived assumptions? Is it bias? Um, I once said to the attending in the ER, I'm going to go look at the waiting room and see what's going on out there. And I went to the door and I just went to the other side of the door and it was packed. And I looked at everybody. I just looked and I put in all this data in my brain. And I went back to the attending and she said, "Oh, so what do we got?" And I said, and I just rattled off, well, we've got so and so who's back again, probably for this, and I gave like a report. And she looked at me and she said, "Did you talk to all those patients?" And I said, "Wow, no, I didn't." I just looked at them. I made judgment. I treated it like it was real data and information. And that whole time, I was being biased. So being cognitive of how our own previous experiences and exposures influence us, and perhaps recognizing that sometimes we may jump to judgment too quick, is one way of being self-aware. And this is a normal function, but often it has consequences that are unattended if we let that get too much into our frontal cortex. Um, and so I think that there's a website here you'll see that I put on the slide. It's free. You can take the test yourself. It'll give you some feedback about bias and stigma. I was horrified when I first took it. I went to lots of sessions on this and ways to be more aware, and took it a second time. I liked myself a lot better the second time. But it is amazing how it just creeps in and shows up. So we're gonna watch a little video about this. So I think the video's next. So yeah, as we get to this video, I really always think about, is it worth spending time on this? And I always come to the conclusion it is, and they're going to bring this up. It's very short. It's maybe 3.5 minutes. But I think it nicely says what I think. So we'll go forward.
Have you ever felt left out or judged by people because they thought you were different from them? Maybe you've been discriminated against. How did this affect you? Maybe you felt misunderstood, embarrassed, alone, or even afraid. That is what stigma might feel like. So what is stigma? Stigma is a set of negative beliefs and prejudices about a group of people. Stigma also includes negative behaviors towards groups of people. Many people face stigma because of their race, religion, sexuality, gender, economic situation, and a variety of other things. People living with mental illnesses often face stigma and discrimination. This can make them feel ashamed, hopeless, distressed, reluctant to get help or accept help, and feel like they are to blame for their illness. In fact, almost half of Canadians thought people use the term mental illness as an excuse for bad behavior, and 27% say they would be fearful of being around someone who has a serious mental illness. Why is that? Well, many years ago, mental illnesses were not well understood. We didn't know how mental illnesses influenced a person's brain or affected their thoughts, feelings, and behaviors. People with mental illnesses were not treated with the support they needed and were considered outcasts or even dangerous. To end stigma, people need to understand and accept that mental illnesses are like any other health conditions and need the right treatment. We would never say to someone, just think positively and your diabetes will go away. But how many times have you heard, try to be happy, think positively, Don't be so depressed. You have so many good things in your life. Now let's look at an example of how stigma can hurt someone. Stefan is a first-year university student. He likes his program and has some new friends. However, Stefan feels stressed and overwhelmed by all of his schoolwork and being away from home. He's not feeling like himself, and most days he doesn't want to get out of bed. He's afraid his friends will think he's weak if he tells them, and he doesn't want anyone seeing him at the clinic, so he doesn't reach out for help on campus. His feelings get worse, and he's having a hard time staying in school. Like with Stefan, the stigma people experience often prevents them from getting help and support from family, friends, and professionals. We know from research that the sooner someone gets help, the better the outcome will be. This is true for all health conditions, including mental illnesses. So, how can we reduce stigma and help people like Stefan? 1. Think about your own feelings about mental illnesses. Do you have biases or judge people? 2. Be aware of language. Avoid using words that can be hurtful, like psycho or crazy. 3. Think about and discuss what you see in the media. How people with mental illnesses are shown in the media is not always accurate or fair. 4. Learn more about mental illnesses. Check out trusted websites like the Canadian Mental Health Association or Bell Let's Talk. 5. Explore relationships with people in your life who have mental health challenges and illnesses. After watching this video, make a list of ways you can help yourself and your communities become more accepting of all people, including those of us living with mental illness. Think about one thing you can do now to help reduce stigma around mental illness. It could be a small thing, like not using hurtful and labeling words. It could be reaching out to someone who you think might be struggling and encouraging them to get help. It could be sharing your own experience living with a mental illness with someone you trust, if that feels comfortable and safe for you. All of these things help reduce stigma and keep it from stopping others and ourselves from getting help when needed. For more info and resources on stigma, check out havethattalk.ca. Brought to you by Ottawa Public Health with support from Bell Let's Talk. Have you ever felt
Thank you. I'm going to use this video in many places. I was trying to find something on stigma, and I feel like it just fell out of the sky in my lap. What I hear in this video is who gets included and excluded. And I think we've all had the experience of being excluded from something in our lifetime and reflecting on that, how it makes one feel, right? It makes one feel sad, um, lonely, alone. Um, and I love the piece in it about really self-reflecting. Um, I think that that helps one to really address what they do have control over, which is their own perceptions and their own personal growth. And I really appreciated like the language piece. And I'm going to address that actually here in documentation, so I won't spend much time here. And then the impact of social media um, on on either promoting false information um, or stigmatizing um, people. And we're seeing so much of this down here in the States, right, with um, immigration and people looking at that and thinking it's right to arrest people and in front of their children or to take children. It's really painful. But I will watch this over and over again because this is probably my third time watching it now, and every time I come away with it with something else. And I do think about stigma and bias in our topic area today, which is intimate partner violence, and how um, we don't always understand, so we jump to sort of stigmatizing language, refuses to leave, um, has um, hard to believe this story. Why would she go back over and over again? How that kind of creeps in. Um, So you'll have the link to that video. I hope you'll maybe share it and have some discussions in small groups. I always find that little videos like this can take us far. So I'm going to jump into inquiry. A lot of this is lessons from the field, and then I've learned probably a lot, quite a bit from the literature, but also from clinical practice, and I want to share that with you. I'll take the next slide. So many people think that in screening or inquiry, which is what I call it, that the main goal is to get to a disclosure. And I'm here to tell you that disclosure is never my goal. Um, Sometimes asking the questions and getting a negative answer um, allows a patient to reflect on it. And just because we are clinicians and nurses, we shouldn't have the expectations that any question we ask should be answered. Um, I think that the real way to build a relationship with a patient is to provide that safe environment for them and allow them to share whatever they're comfortable with, as much or as little, without any judgment. Um, so I'll get a lot of calls from the ED about they believe that this patient is being abused, but they refuse to disclose. And I say, sit tight, I'm coming down. That's an opportunity to talk about it. Patients do have the right to not tell us their story or any details about the story. That is their prerogative. And maybe they don't want to tell you that day. Maybe they'll tell you another day. But if it comes across that you've judged them because you've been like, really, are you sure he's not abusing you? Then that patient likely won't come back and certainly isn't going to disclose. I think that a lot of inquiry comes with universal education. I'm not going to ask a question without providing a phone number or someone to contact and keep it simple. And I always want to balance my questions around trauma inquiry with strength and resilience. So we ask all our patients. It's one of the first questions we ask when they come to clinic. And it is also the first thing we address in our trauma-informed care plans, which is tell me about some of your strengths. What are you good at? What are you proud of? You have any hobbies? I'd love to hear about hobbies. So that we're balancing our inquiry with them to not pathologize everything, but to also lift up their strengths. Next slide. These are questions that I developed some 10 years ago, not even more now, I guess it's 20 years. Please feel free to use them. Um, I really love the first one. It has opened up a whole world of inquiry for me. I ask patients, has anything happened in your life that you feel had a direct impact on your health and your well-being? I have had 3 patients in plane crashes. I mean, astounding. Now, the curiosity in me and the nurse in me wants to know what airlines were you on? Where were you going? Who were you with? But that's the curious side of me, right? Why would I ask those questions otherwise? Um, My next question is always, how do you feel this has affected you? Um, I don't screen for ACEs. I have some mixed feeling about that. That could be another whole webinar. Um, but if someone says to me, I had a really crappy childhood, I don't then go into details with them. I don't say, well, tell me what happened and tell me more and who did that and when did that happen? If someone defines for me that their childhood was really crappy, I don't dig into details. Because I find that knowing that I'm not a therapist, I'm therapeutic, but I'm not a therapist, wasn't helping me. I was having them relive everything with me, and now they're going to go talk to a therapist or talk to someone else. But I did find that asking them, How do you feel this has affected you? I don't trust people. My childhood was so crappy. I'm still depressed over it. I drink all the time. Now, those are things that empower me to help. So the details of stories, unless it's acute. If it's an acute event, everything changes, right? If it acutely happened, I need to know what happened, when it happened, how it happened. But if it's something that happened a long time ago, like a plane crash, I don't need to know the details of it. I also had this question that I asked a young girl who kept coming into our emergency department over and over. The nurses felt that she was being trafficked, and they asked her questions about anybody coercing her to do anything she didn't want and all that. And she was coming in a lot. I pulled up her record and I looked, I'm like, oh my gosh, she's been here almost every week for 4 months. I went down, I asked her that question, and she said to me, she just looked up, I'll never forget it. She goes, wow, no one's ever asked me a question like that. Um, and she looked me right in the face and she said, when I was 15, I was in a motor vehicle accident and my three best friends died. So I was like, thank you for sharing that. Can you tell me how that event occurring has impacted you? And she says, I don't want any friends. I isolate. I think about it every day. And mind you, she said she had no counseling or therapy after that. Um, and so it was a major traumatic event in her life. Um, and she wasn't being trafficked. She was self-harming. She was drinking. She was isolated. Um, a happy story with her is she got her social work degree 2 years ago and is working in the field now and has friends and um, did all her schooling online until she had to do clinical, but with the right therapy and everything, she got there. The other question I really like is, have you had any experience with the healthcare, with receiving healthcare that you feel I should know about? There's a lot of things that happen in healthcare that have traumatized people. I've had a personal experience, definitely traumatized. I was given too much narcotics after having surgery on my hand. And I was in the car, my daughter was bringing me home, and I became unconscious. Um, my daughter, it took her 6 months because she thought I was dying. She didn't know what was happening. And I ended up in an ambulance back at the hospital where I found out they gave me too much narcotic. Um, I had a patient who just refused to take her thyroid medicine. And I got at it. Why? People were labeling her. She is uncooperative. She refuses to take her medicine, right? All those labeling terms. And I popped this question to her. And she told me when she was 12 years old, her mom died from a medical error. So people have had things happen to them in coming to healthcare. Women of size have been stigmatized for years. I once had a following of patients that needed pelvic exams, and they were all women of size. And listening to the stories they told me about how people talked to them and treated them was horrific. So I do think it's a good question. I think it validates that our system is imperfect and that we are sorry that you experience that, and we'll do everything in our power that we can control to not have you have a similar experience. And then always asking what would make them most comfortable and safe. I've I've had people do many different things during a visit that makes them helpful. Makes them feel, grounded and find it helpful. Next slide. So who's going to ask? When are you going to ask? Where are you going to ask? And how are you going to ask? All those things should be discussed and agreed upon so that not everybody's asking and it's not at the right time. And the example I always like here is I first recognize that we were asking about IPV at triage in the ED. I was like, who decided this? Because it really doesn't make any sense. They're only there for a quick check, blood pressure, what brings you to the ED. So the where in this kind of open area and who is asking, the timing of it was all wrong. Checklist questions, I'm not a big proponent of. Yes or no? You kicked, pushed, or shoved? Yes or no? Um, it's dichotomous. It doesn't often yield what we're hoping it will. So I like to ask more open-ended questions when it comes to IPV. We can start out with a couple of maybe checklists, but I think that we really need some open-ended questions. I like to ask about relationships. First, I want to know if they're in a relationship, because if they're not, why are we even asking? And then I tell them feel comfortable to share what you're comfortable with. What goes well in your relationships? All relationships have things that are great in it, and then maybe some other struggles. And how do they resolve arguments or disputes? So a little bit of open-ended to go beside some of these checklist questions is my recommendation. Next slide. So this was in one of your reports that I read, and really I was a little. First of all, I thought it was great that there's a death review committee, and this one was just published actually November 2025, and it looked at 2 years earlier. But there were 28 cases involving 43 deaths. And I think that knowing this data for you all is really important, because this is a nice report written up. It did show that guns were used in many of these cases, which may signal to us, should we be asking if there's a gun in the home and where's it stored and are the bullets in a different place. And it also highlighted mental health in many of these cases. I find such reports are really helpful. I always look at local numbers and see what's happening in my community too, and it helps me to think about maybe questions I should be asking. What is the purpose of a risk assessment? It's just that. It's to understand whether there are certain risks that um, are are occurring, so that I find in often asking some risk questions is also an opportunity to have this dialogue with the patients that they may not realize they're at risk until you actually ask some of these questions. And I've had many say, "Oh my goodness, I haven't thought about it this way." Um, if you are doing risks, you do have your resources readily available. What do we have internally, and what do we have within the community? And have them ahead of time so that you're not searching for them. And then again, who is going to do it, when, and how are really questions that should be answered up front. Next slide. We want to avoid asking why questions. Okay, why did you leave? Why did you go back? Why didn't you get a restraining order? We want to do everything in our power to not. Help me understand what the obstacles have been for you is a much better question than why. I always thank people for sharing with me, and validate. I'm so sorry this is happening, and I mean that genuinely. Thank them, and pat yourself a little bit because you opened up or you approached this in such a way that one felt that they could share. I always say to patients, you can tell me as much or as little, and we can stop whenever. So I let them know that they have agency and that I'm on the bus with them, but I'm willing to stop anytime that they decide we need to. You want to contain details, and really not encourage people to keep talking about all the details of the event unless it's acute, um, because that's not helpful. Um, and this is my favorite. Does your partner ever make you feel afraid? It is hands down my favorite screening question, because no one should ever be should feel afraid when they're with their partner. And I've had two, more than two, but two cases I'm going to share with you really quick because I'm noticing time. Um, One was a young woman who denied that she was ever forced to have sex with her partner, denied hit, kick, punch, denied threat, didn't deny threats actually. Um, Really on the assessment tool, and I can't remember which one we used at the time. No, no, no. But then I asked her if he ever made her feel afraid, and she got quiet. And she says, "Well, my partner's going to jail for a year, and he came over to my house the night before, and he put a gun to my head, and he said I better not cheat while he's in jail, or this will happen." And he pulled the trigger. Um, Obviously not loaded, and I was horrified. I wasn't prepared for that. But he never ever did anything else except that, and that's huge, right? Another patient, she said she only was made to feel afraid on Fridays. Um, and so my next question was, what happens on Fridays? Well, her partner drinks, goes to the pub, comes home drunk, and insists on doing the food shopping on Friday nights because the market's too busy. And he never allowed her to get her license. So she would have to bundle the kids up, put them in the car while he drove drunk to go food shop. It's just a great question. I could give you a million other examples. Those were two that I share that really kind of shocked me. Um, and then I do ask all patients, I say I ask all questions because of my experience and knowledge, but I always ask about strangulation. That's what scares me more than anything. Next slide. I know because I have spoken to Dr. Jackie Campbell, and I know she loves sharing this tool, and especially in Ontario, where she said she's done quite a bit of work. This is a nice little tool. When this tool was first developed, there were 20 items in it, and I remember speaking with Dr. Campbell, and I said, going to have a hard time selling that tool in a clinical setting with 20 items in it. And so she has gotten it into this 5 questions, which I think actually I use it and it's very helpful. And then oftentimes I will refer to our advocate for more in-depth risk assessment. And I've given you the link to it there. Next slide. Okay, we can keep going here and fly through some of these. So I just love this, that the way we tend to write and talk about people is really the way we relate to them. Would you agree with that? So if you say a morbidly obese, homeless, drug-seeking patient in room 3, you've already got some bias going on in your head. So how we speak and how we write about patients and how we talk about our colleagues absolutely has a direct ramification on how we treat them and how we view them. We're getting there. I think we're getting away from those labels and pejorative terms. And really, the goal is to always use person first language. Annie Lewis O'Connor, who's here with thumb pain, right? It's not the woman in room 3 with thumb pain. I like to think that we can keep correcting this till we get it right and we get it consistent. Next slide. So the person first language, we're gonna try to decrease stigma by doing that, avoiding all those pejorative terms that we've so long written into records. And we're gonna set an example when we're collaborating with others on the medical team around language. So when I get a call, I will reiterate back to them. So I understand the patient's name is, and I am shocked how many times people don't know the patient's name. The clicking of the keyboard. It's like, oh, it's pretty, all people want to be known by their name and then tell me what's going on without any of these other terms used. Next slide. So in documentation, I'm not sure whether you carry laptops when you do home visits or what that's like. And I don't know all your clinical settings, but I am encouraging people to share the screen when they can. When I'm doing a reconciliation on medications, I have the patient sit beside me and I pull up the meds. If I'm doing a PHQ-9, I have them sit beside me, and it's one way to build trust and to demystify what we're putting in the medical record. And remember, it is their medical record that we house for them. I've talked about the minimal details and the need to know. I really like the SOAP. The patient states this. This is my exam or what I'm observing. This is what my assessment is, and for every assessment that there's a plan. It's just nice and clean and focused. Um, and I also think documenting patient strengths, which we've talked about, and really figuring out how the team's going to communicate. So my team uses text messages on secure hospital phones that were given, and just to let the team know when we've seen a particular patient, a quick update. We can also use Epic for that, but our volume is such that we are able to do that for our patients. Next slide. Summary. We've gotten there. You can keep going. So in thinking about the framework that we've been talking about, TVI, and TIC, it really aims to strengthen the relationship that the patients have with us and that we have with the staff we work with. It's an empowering model. It really does allow and should allow for voice and choice, despite what we think might be the better choice, right? And we're going to suspend that because we really want to foster autonomy and the regaining of agency for patients that have experienced IPV. We recognize that every person needs and has some degree of uniqueness, right? We are not all alike. And so how can we use this model to really foster that? Because this isn't a cookbook recipe on how to approach IPV. It's individual, but using those guiding principles that we've talked about. And also acknowledging that we do have people that work before us that are experience IPV as well. Okay, so next slide. I think that this is where, as organizations, we need to move towards, and so that it is consistent and that it is more a cultural shift. Um, And I am proud to say that in some of the organizations I've been working with on becoming trauma informed, I'm really seeing some nice progress, particularly as all these items that I've listed here are being addressed proactively and not in response to. And that when we think about partnering, we really want to work hard on leveling power dynamics between ourselves, these patients, and our colleagues, and put people with lived experience right in the front and center. And then self-reflection, I think, is something that we don't do intuitively, but I build it into my day. I build it in at the end of the day. I stop, pause, I reflect on the day, what went well, and what could I have done better. And just taking that couple of minutes every day, I find is very what's the word I want, is grounding for me. Next slide. Just always enjoyed the work of Nelson Mandela, and particularly his lived experience in life. And this is a quote by him: "Don't judge me by my successes, but judge me by how many times I fell down and got back up again." And that is that really speaks to me around IPV and people that are living with IPV. Yeah, it may take them a few times, but if we can allow them the opportunity to get back up and always receive them without judgment or without prescribing for them, but letting them know we're a safe place for them to be without judgment. I do think that we will be providing the best and most authentic type of care possible for these patients.
This is great. I mean, first, thank you, Annie. Thank you for grounding this work in your reading and reflecting on your experiences working with women and families from your own nursing practice. It really brings this alive. And the chat is moving so quickly, I can't even read all of them. Um, but I think what you have done today is shared some new insights, but I think even more critically validated to people that what they're doing is already really good nursing practice, right? The
Mm,
validation, giving opportunity to share. And as you're speaking and as I see what everyone is identifying, I think how important it is for our organizations to really rethink the use of time. All of our organizations, so not picking on any one,
mm,
have so many requirements and agendas. How many assessments we have to complete, how many
yeah.
forms we have to complete, consents, um, telling people about mandated reporting. There's so many things from an organizational due diligence level that we have to do that often that is at the start of the interaction. And I think it overwhelms and it frames the whole interaction. Whereas, is there a way within our organizations that we can shift that the start of our interactions with people are on all the things you did? Like, so being curious, tell me about yourself. Let me learn a little bit more about
Yes.
you. What has happened to you? One of the things that I think you said that was really powerful was, can you tell me about any of your past healthcare experiences and how might this influence our interaction today? Because often people are
Mm,
scared, they're freaking out, they're anxious. We don't know why, but maybe it it is something small. If we just understand that, we can change how we interact with them. So I think as organizations, we need to rethink the use of time and
mm.
provide flexibility to clinicians to really think about um, focusing interactions on the client's agenda first before we move into all the things that we have to do. Um, so I mean that's sort of what one of
I
the things I
so agree
took
with
away.
that because, yeah, we lead out with what we need to get done. And what if we led out with what are you hoping to accomplish and then go from there? Yes.
Yeah, I think it would change, and I fundamentally think it makes our lives easier. I mean, we do have an agenda, and we have a goal, which is to provide um, care or education or health promotion interventions. I mean, we're stepping into people's lives with intent, but there's always challenges to delivering care, health education, health promotion. So I think if we swift that narrative, it'll make the clinicians' lives a bit easier. But I do have a couple of, we only have a few minutes, but I do have a couple of questions for you. One is specifically around the danger assessment, and thank you. And through PHN Prep, we did work with Dr. Jackie Campbell to develop a practice guidance resource. I put it in the chat that supports
Ah,
public health nurses to know how to introduce, how to administer, how to score, and how to interpret the Danger Assessment 5. But a question that I would really, we'd appreciate your insight on is when you have to do a risk assessment, let's have the assumption that we know that someone is experiencing intimate partner violence because now our goal is to determine risk. In my brain, I know as a nurse that I'm doing a risk assessment because I need to determine how much danger this person is in or what is their likelihood of femicide or being killed. Now, I can't say that to a client or a
mhm.
woman. Maybe I can because that might really scare someone,
Yeah.
particularly if they're in those early stages of pre contemplation or that really committed to the relationship. How do you tell someone in a trauma and violence informed way that you're going to do a risk assessment and the purpose of that assessment without adding anxiety?
Mm. Yeah, I mean, I think it's every person's individual. If
Hmm.
they already seem dysregulated, I might say, would you like a sandwich? You just got to roll with it and trust your instincts. So say my assessment is I I think she's in a good place for it. I'm just honest, Susan. I just say to them that I have a few other questions that I'm going to ask because depending on how you answer them, it would help me to think about the resources
Okay.
that I'd like to provide you with, should you want to take them now or not. I had a strangulation patient that actually came in with him and was discharged home with him. But we got her a loan to go through that. And 3 months later, she called from another hospital and wanted to come back. So we may find the risk is really, really high. And I just say that worries me. If they say
Okay.
they've choked them, I say that worries me because what I know from reading and keeping myself on top of this literature is that is really dangerous.
Mm.
But no matter what you want to do, I am here unconditionally to support you. So I want to make sure that they leave and they're not going to think that I scolded them or shamed them, that they'll come back. That's the measuring factor, that they came back.
Okay.
So
Excellent.
it's
Thank
individual.
you. So me, individual, meeting them where they are, being honest, and I think framing it as, well, it might be difficult to ask these questions might be difficult to hear, difficult to answer. It is for the intent of supporting you and
Yeah.
securing resources and linking. So thank you for that.
Mm.
Another question, um, well, I'm going to look to the one before I ask my second question, but someone else has followed up on a similar question. How do you introduce the assessment of IPV risk while knowing that the answers they provide may require a nurse to call Children's Aid Society, like CPS, Child Protection Services?
Mm. That's an excellent question. I certainly, when I was doing primary care, that came up quite a bit. Again, if I do say that there's certain things that are reportable. IPV in my state is not reportable.
Okay.
It's not reportable. If I lived in California, be having a different conversation. So I tell them that. However, I also say that if in your sharing, you have shared something that a young child in the house, has been harmed in some way, the law does require me to report that, but we can do that together. So I don't want them to think that I'm reporting you because you're never reporting the person. You're reporting on behalf of the safety of a child. And that framework to me is different.
And I agree. It's a thoughtful framing, and I think again, it's all in about. It's not what we do; it's about how we do it. Explaining why we have to do things,
Yeah,
how we do it. Is it safe to engage the person in that process? And I think there's still work to do in all of our communities around working with our local children's aid societies, child protective services, for them to deepen their understanding of the mechanisms of intimate partner violence so
yeah.
that when they come in for their assessments, there's not blame on the mother for staying. I've
Yeah.
often heard, well, as a mother, how could you keep your child in this situation? And in my
Mm,
mind, I'm always like, well, her partner said he would kill her or the child. She,
right.
right? Like there's reasons
Yeah,
why they
yeah, yeah.
stay. So my last question is, is related to the risk assessment, the danger assessment. In the instructions of the danger assessment, it does say the woman or the individual's perception of risks will override the score, particularly if there's a low score. So if we're doing the full danger assessment with the
Hmm.
20 questions. So if we imagine that the score is a 6, very low variable risk, but the client says, I am frightened of my partner, I'm very scared. Well, we go with that, right? We go with
Yes.
that rather than a low score. So that I
Yeah.
understand. But recently I was out at a health unit doing a full day workshop on risk assessment and had a great conversation with a public health nurse around the reverse. And I don't know if I had a great answer. And the reverse is that you do the full danger assessment and the score is high. So 18, severe danger. But the client experiences a moment of cognitive dissonance and they say, that can't be right. I'm not in that much danger, and get into the cycle of abuse. He's only done this a few times. I believe he's going to change. I don't believe that I'm at that much risk and your tool must be wrong. How do you navigate that then?
Still with universal education.
Okay.
You're right. We say that women are experts in their own life. And tools are great. And Jackie's tool, the work that went into that, it doesn't account for all human errors in life, right? There's a couple of questions I like to add before I do the risk.
Okay.
What's the worst thing your partner's ever done to you?
Oh, powerful. Yep.
And boy, none of those things are going to get captured. Some of those things would not get captured on Jackie's tool. Um, I've heard stories of rape. I've heard pouring scalding water over like just if you let them define what the worst thing is. Um, and then I always ask about the guns and I always ask about strangulation because our literature is very, very clear on that.
Mm-hmm.
So I like to get those out, and then our advocates do the longer assessment,
Mm-hmm.
um, and we combine it, and we do listen to what the patient's saying, and develop the plan of care that they can live with. That it sets them up to feel successful, not setting them up to meet the expectations that we have.
Mm-hmm.
We want to meet their expectations. It's not the other way around. So, are you okay if I call you on Friday when he goes to work every week?
Right. Okay.
Right. So, we make the plan and we do it with them. So keeping
Yeah.
them engaged, and even if it's just a touch, I just want to hear your voice and say hi and ask you how the kid's doing. Could we do that once a week? So we really do, and we have team meetings about that plan of care.
So the follow-up is important. There may be cognitive dissonance.
Hmm.
We recognize the impact of a high score and the need for linking with supports resources to
Yeah.
personalize it, maybe look at some of the individual risks then and begin to do safety planning again at that individual level and then
And
follow
some
up with
harms
clients.
reduction, right?
Yeah,
Around, yep. Like the woman that was, her husband was drinking and putting her in the car. It took her 4 years before she left him.
sure.
She got her English degree, she got her driver's license. But in that time, we knew about Fridays. So her sister would come over on Fridays and say, how do you go? My sister and I are working on something together. And the sister would bring her kids so that they couldn't all fit in one car. Like we
Yeah.
just thought about harms reduction.
Harm reduction and different strategies. Well, those are great principles to end on. I could sit and ask you questions all day, but again, we are at our time
Yeah.
as Dr. Lewis O'Connor, thank you so much for taking
Yes.
time from
Thank
your
you.
practice, from your work, to share your wisdom with nurses across Ontario. And to everyone out there, thank you for joining us today. You can expect to receive a brief and anonymous survey for today's session. Please complete it. It helps us improve all of our webinars and identify what topics you want to hear from. And I just wish everyone that you have a wonderful and safe day. So thank you, Annie, and goodbye,
Thank you.
everyone.
Have a wonderful holiday season, everyone.